I want to talk about incidental pulmonary nodules, and I think that's really the bane of our existence when you're a chest radiologist. Nodules belong to everyone. I think if you have lived a good life and you have any experience and you don't have a nodule in your lung, you probably really haven't lived fully. So this is a problem that faces all of us, and I'd like to give an overall review of the incidental pulmonary nodules and how we manage them and how guidelines for management have changed over the past year. The problem that we have is a small pulmonary nodule, and how do we define that? Well, it's usually a nodule that's less than 8 millimeters in diameter, and the very vast majority of these nodules are benign. So their clinical importance is less than large non-calcified nodules, and they're extremely common incidental finding. And it's often that patients who are referred for CT for reasons not related to lung cancer are going to have a nodule, and often they have more than one nodule. So risk stratification is very important. And I think sometimes as radiologists we realize when we decide on risk, we focus on the radiologic and imaging findings such as the size and the shape of the nodule, but it's important for us to consider the clinical risk factors. I think now it's easy with the current technology we have that we have easy access to patient medical records, and we can check for these clinical risk factors if they're not made available to us in the history. So they include, of course, older age, history of smoking, a history of an extrathoracic cancer within 5 years for the suspicion of metastatic disease, a family history of lung cancer, and of course the presence of emphysema. COPD in its form of emphysema and chronic bronchitis has a high association with lung cancer. And then of course we look diligently at the characteristics of the nodule. Size is important. Once you reach that 8 millimeter threshold, the likelihood for malignancy escalates. We've been taught since our days in residency the border characteristics are not infallible, but they're helpful in determining the risk of whether a nodule is indeed a lung cancer. The density of the lesions, the lack of any calcification, the absence of fat brings up the likelihood of malignancy. And now we have to deal, of course, with both solid and non-solid nodules. Growth is helpful, and I emphasize to my residents, make every effort to see if there are previous images. You can save the patient and yourself a great deal of anxiety and trouble if you can prove that a nodule has been stable over a period of at least 2 years. And then location's important. Now, how do we define nodules? Nodules, by definition, are greater than 3 centimeters in diameter. They're surrounded by aerated lung. The sub-centimeter nodules are the ones we're most concerned about and are defined as small nodules, less than 8 to 10 millimeters. The classic solitary pulmonary nodule that you might pick up on a standard chest radiograph usually has to be at least 8 to 10 millimeters to be visible. So the fact that you see it on a plain radiograph is concerning. And then there are a lot that are indeterminate. Where there are none of the classic findings for a benign nodule. They're not calcified, there's no fat, and unfortunately we have no old studies for comparison, so we don't know whether they've been stable over a period of time. Now, there are ways to make presumptive benign diagnoses, and I think we have to remind ourselves of this fact. And that's why it's so important to look to all studies. If you can prove that a nodule has been there and it's been stable for 2 years, and that's excluding ground glass nodules, which require further or lengthier follow-up, then we can be pretty well assured that the lesion is benign. The doubling time for malignant nodules can be in the range of 30 to 450 days. Now, calcification we all know about. If the calcification is diffuse, central, laminated, or popcorn, we're dealing with a benign lesion. The presence of fat can either indicate a localized aspiration pneumonia or lipoid pneumonia, but more commonly a hamartoma. And then those that are less than 4 to 6 millimeters are almost invariably benign lesions. Periphyseal nodules have been shown to be benign. And in any of these criteria present, we just don't have to do any further evaluation or any further follow-up. I'd like to emphasize that thin section CT is recommended for screening, but also for the analysis of these incidental pulmonary nodules. And the preference is for thin section CT in the range of 1.5 to 2 millimeters. Now, this is a very sophisticated audience, and I don't have to go through calcified pulmonary nodules, but just for the purpose of emphasis here, we know the types of calcification that can be seen in benign nodules: diffuse, central, popcorn or laminar, and concentric. Eccentric calcification can be present in malignancies. And a couple of examples: a calcified granuloma, another calcified granuloma with central calcification. This is typical of histoplasmomas for a reason. Popcorn calcification, classic for a hematoma. And here we can see an example, not of calcification, but fat density, 2 examples of hamartomas with internal fat. Now, periphyseal nodules are interesting. There was a paper that was published a few years ago from the group of Vancouver, and they found that up to 1/3 of all nodules that they found in the context of lung cancer screening, these are not incidental nodules, but in the context of screening, were periphyseal nodules. They're usually small, around 3 millimeters, and the shape is awfully important. They have to be triangular, oval, and touch the fissure. If they become irregular, or if they cross the fissure, or there are other shapes, then the likelihood of malignancy can go up. They're located, most of them below the carina, so you'll see them usually in the major fissure in the lower half of the lung. And they consist of subpleural lymph nodes, so they can wax and wane. They respond to inflammation or to whatever may be inhaled, and they may change over time. In this article that was published in 2010, with a 7-year follow-up, there were no cancers among all those periphyseal nodules. And here's a classic one showing that nice oval shape. Now, the exception is, if that nodule were to cross the fissure or become spiculated or irregular and doesn't fit the classic description, then one has to be suspicious of a lung cancer. But in this classic size and shape, you can dismiss those without a concern for lung cancer. Unfortunately, in the lung cancer, the LRAS, which I'm not going to talk about, which is in the context of screening, periphyseal nodules still have to be reported and followed. But I think it's pretty obvious that they're benign. Now, solid nodules, when do we get concerned? What about malignancy, and what is the malignant potential? Well, it's related to several factors as far as the risk factors from imaging are concerned. One, of course, the size, location. Nodules in the upper lobes are more likely to be cancer than nodules in the lower lobes. The margins and contour are important. And then internal characteristics, eccentric calcification, cavitation, air bronchograms. And then importantly, the growth rate, if you have the benefit of all studies. Now, it's been shown quite many years ago that small nodules, the ones that are less than 4 millimeters, there's a less than a 0.5% chance of lung cancer, even in smokers. And we'll talk about the Fleischner guidelines, but they've been changed to increase the threshold size of which we begin to get concerned and need follow-up to 6 millimeters. So these very small nodules we can probably forget about. And as you know, in the National Lung Cancer Screening Trial, the false positive were over 90%. And that's because the criteria included nodules that were 4 millimeters or greater. But those are almost always benign. Nodules, when you get up to the range of 8 to 10 millimeters or greater, have a 10 to 20% chance of malignancy, even in non-smokers. Just a couple of studies here looking at the prevalence of malignancy. Now, this varies widely, and it depends upon the group that's studied. But in a group of patients having FDG PET studies, and you would imagine that there are likely to be people at risk for lung cancer, but they show that nodules 10 to 20 millimeters in size had a 33 to 60% chance. That's the range for all the studies. And nodules greater than 20 millimeters, it goes up to 64 to 82%. So size is important. Margins and contour. And I think we probably all learned this when we were residents, but lesions that have an irregular contour, spiculated margins, or this lobulated, or have a pleural tag. A pleural tag can be fibrous tissue, but it may be an indication of extension to the pleural surface of tumor, or it may be a fibrotic response to the tumor. And we see an example of that here, and a nice example of a spiculated nodule on the right-hand side. Okay, internal characteristics, eccentric calcification, cavitation, air bronchograms, adenocarcinomas may frequently have air bronchograms, may all be a sign of malignancy. And some examples here. Now, these are obviously not small nodules, but I'm using this for illustration. You see eccentric calcification. This was a lung cancer. The presence of air bronchograms, spiculated margin here, another malignancy, and a cavitary nodule. So all these factors make malignancy more likely than not. Growth rate, and again, I would emphasize that if you make every effort to see if you have prior imaging studies, the absence of growth over 2 years is generally considered a sign of benignity for solid nodules, not non-solid nodules. And again, emphasize that you need thin sections. And just to remind you, the doubling time, 25% increase in diameter is equivalent to the volumetric doubling time. And for benign lesions, it's usually less than 30 days or greater than 450 days. Now, here is an example of relatively short-term follow-up. I'm going to show this case later in my second discussion, but this measured a little bit less than 6 millimeters, which is actually the cutoff for deciding whether this needs any follow-up. This patient has had some risk factors, and you can see in 6 months, not only has the size changed, but it's become spiculated, and this was indeed a lung cancer. Now, what's the usual management? How do we manage these small nodules that we see all the time as we read CT scans that are done for other reasons, the incidental nodule? Well, the Fleischner Society came out with recommendations back in 2005, addressed only solid nodules, not part solid and not ground glass nodules. And then new guidelines based on revisions from information from other studies from lung cancer screening and so forth were published in 2017 and dealt with incidental nodules that were both solid and subsolid in nature. Now, the important revision to the guidelines, and one is certainly, I think, beneficial to us as radiologists and, of course, to patients, is the minimum threshold size for routine follow-up has increased to greater than or equal 6 millimeters. So we can, for the most part, dismiss those very small nodules that we see frequently in almost all patients. The follow-up, it was rigid in the first, the criteria for follow-up, or the standards for follow-up were very rigid in the first 2005 classification, but this gives a range of time based on risk factors and the preferences of the patients up to a point. Solid and subsolid nodules are addressed and simplified in a table. And then also the issue of multiple nodules, which are a common finding in many patients, is addressed. Populations not included, and this is important to emphasize. The Fleischner guidelines for incidental nodules do not apply to individuals younger than 35 years, those with a known primary lung cancer, or immunocompromised patients who may develop nodular infections. Now, here are the Fleischner guidelines, and I think it may be difficult for you to read the fine print, but I would just like to emphasize a few important points. If, first of all, dealing with a solid nodule and dealing with a solid nodule that is truly solitary, if the patient is low risk, and there are multiple factors in that, and I recommend that you read the paper, but generally we're talking about younger patients, and we're talking about patients that are former smokers or have never smoked. You really don't have to follow these up. However, you're allowed some degree of discretion. And they said some nodules that are less than 6 millimeters do not require routine follow-up, but certain patients at high risk of suspicious nodule in the upper lobes, you may want to do a follow-up at 12 months. And that makes sense. You see a spiculated nodule, it's ugly looking, the patient's never had a prior study, it may be reasonable to get a follow-up in a year. So it allows the radiologist and the clinician some discretion in following the guidelines. And I won't go through all these, but it becomes obvious that once you get to that critical threshold we talked about, which was 8 millimeters, then you really have to start getting aggressive. And it may be that, again, you see a patient who maybe has an 8 mm nodule, but it's smooth, there's no speculation, it's in the low lobes. The patient has never smoked, never had a family history of cancer, not exposed to anything that's carcinogenic, and you may decide that you don't need a follow-up, or you can follow up just at 3 or 6 months, rather than being more aggressive and doing other studies, whether it be a PET CT or actually choosing to do diagnostic, more invasive position, whether it be a percutaneous biopsy or bronchoscopy, but actually providing tissue sampling. Here's an algorithm that I think is a little bit simplified here, but it helps particularly in dealing with the greater than 8 mm nodule, the nodule that is incidental but is concerning for lung cancer. One is to look at the clinical pretest probability of it being malignant, the patient's smoking history, as we mentioned, the presence of COPD, history of lung cancer in the family. And you can stratify these depending upon not only the clinical factors, but also the appearance of the nodule itself into low risk, where you can do serial low-dose follow-up at 3, 6, 12, and 24 months, even though it's a little bit above that 8 mm threshold. Most patients will fall into an intermediate category, and they recommend then probably doing a PET CT. If that's negative, case-by-case follow-up, but it probably is reasonable to get a follow-up in 3 to 6 months. And if it's positive, then you have to do some tissue sampling. And if the risk is higher than 60%, you're the classic smoker, 65 years old, has emphysema and so forth, you probably should obtain a tissue immediately and then consider the patient for surgery. Now, these decisions are usually made by multidisciplinary committees. In our own hospital, we have a nodule clinic. We look at people who come in with suspicious nodules that are likely to be at high risk, and there is a decision made by a board. It includes a thoracic surgeon, a thoracic oncologist, the radiologist, sometimes the pathologist, to make a decision as to what to do next. Okay, I would like to emphasize that we've been talking about incidental nodules, and if the lung cancer screening, the rules are similar but somewhat different because you're dealing by definition with high-risk patients, and of course there are lung RADS criteria for how these patients should be either followed up or require immediate diagnosis. Now, subsolid nodules, as you know, have been identified and represent the spectrum of peripheral adenocarcinomas of the lung. They can be pure ground glass nodules, or they can be a mixed part solid, part ground glass. That's a little bit of a tongue twister. Now, some very early study that came from the ELCAP lung cancer screening study, and some of the numbers are low here, but it's interesting. Among nodules that they found that were purely solid, the rate of malignancy was low. It was only 7%. Part solid, it was 63%. But the numbers are low. It's only 16 cases. And the non-solid was in between, about 18%. So basically, these statistics have panned out in larger studies, except the non-solid, the pure ground glass. They're often inflammatory in nature. Now, what do we mean by pure ground glass? It's just a hazy increase in opacity, and you can see the structure of the lung and the pulmonary vessels through it. And the differential is extensive. Most of ground glass opacities that are pure ground glass are benign. However, that may represent an adenocarcinoma in situ, what we used to call the old bronchoalveolar carcinoma, that is characterized by lipidic growth on pathology, that is growth along the alveolar walls without filling in the alveolar spaces. Atypical adenomatous hyperplasia, or AAH, is a premalignant condition, but very, very slow in its growth, and usually these do not have to be resected. Inflammatory lesions and focal fibrosis. Ground glass opacities are very common, and you'll see them in a lot of patients. Sometimes they're not clearly defined as nice round nodules, but they may be little focal areas of aspiration or focal areas of inflammation, and you need to follow them up, and they usually go away within 3 months. And here is an example of a mixed solid, mixed ground glass nodule. It's a large nidus of solid tissue, and then the ground glass in the periphery. And what this usually represents, if it's a cancer, and it's likely to be, is that the ground glass component is the lipidic growth of the adenocarcinoma, and then the adenocarcinoma is the solid part is the invasive part. So there is a differential. This is a study from Oedol in 2007. What is interesting that most of these resolve, and he found regression or resolution in 37% of the pure ground glass, and surprisingly about 49% of the part solid nodules just went away on their own. Now, what are the correlations here between the CT features and the pathology? Well, the atypical adenomatous hyperplasia, which is the premalignant, is usually pure ground glass, and so is the adenocarcinoma in situ. As you get to minimally invasive adenocarcinoma, which usually is defined as a solid component that's less than 5 millimeters, a partly solid nodule, the chances of malignancy go up. And invasive carcinoma is usually at least solid, a part solid with a ground glass component. It's never, if it's invasive, pure ground glass. So in subsolid nodules, as we surveil them on CT, malignancy is associated with growth, that's pretty obvious, but also the development and growth of the solid components. So that's what we have to look at over time. And if it's pure ground glass, see if a solid component actually develops. So again, to emphasize, and following these subsolid nodules, if they're incidental, you follow the Fleischner guidelines, and if you see them on screening, there are indications in lung-res of how they're to be managed. And I won't go into the details here of the lung-res categorization. But here's a nice example of a pure ground glass nodule, and then over a period of about a year, it develops a solid component. You might continue to watch this for a while because it's less than 5 millimeters, but it needs careful monitoring. Now, in looking at these nodules, we wind up doing an awful lot of follow-up CT, even though we don't usually recommend follow-up if they're less than 6 millimeters in diameter. This is very expensive, and it's a source of great worry for patients, as you can imagine, when they have to have continuous follow-up. So there has been efforts now to look at multiple factors of risk and to produce calculators or algorithms that allow us to determine the risk, and then work with the patient and the clinician and so forth to decide on how they should be managed. The first group that came out was John Mayo and the group from Vancouver, who actually used data from the Pan-Canadian Lung Cancer Screening Program to determine factors which indicate the pulmonary nodules are malignant or will be found malignant on follow-up. And they integrate both the clinical factors that we talked about that were contributed to risk, as well as the morphology of what the nodules that we see on CT. Since then, there have been a number of other models developed. They depend on a multivariable logistic regression model format. They try to determine the risk of cancer, and they use many predictors, socio-demographic, as well as imaging characteristics. And the predictors of malignancy. Now, female may be a little bit of a surprise, but we're talking often about non-smokers or people that haven't smoked in quite a while, and that's because there is this identified subset of women, particularly Asian women, who develop adenocarcinomas in the periphery of the lung and have never smoked. Family history of lung cancer, increasing age, larger diameter, part solid density, lower nodule counts. So if you are doing a CT on someone and they have small nodules, and they've got about 10 of them scattered in different lobes, the chances are they're granulomas. If you have 2 or 3, then you have to be a little bit more concerned. So the more small nodules you have, the better off you are in a sense. Okay, upper lobe distribution, speculation, and the presence of COPD and emphysema, all are predictors of malignancy. And there is a website address here for this computer-based calculator that takes into account all those variables. And now there are other risk prediction models that are available. Apparently, the Bach model is considered one of the best. There's one that has been developed at Sloan Kettering, and the worst performers overestimated risk by a factor of 2 to 3. And this is an example from Memorial Sloan Kettering of the questions that are asked, trying to determine risk, the age, the gender, number of years you smoked, et cetera, have you quit smoking, and so forth. And this is integrated with the CT and radiographic findings. Now, there are attempts to make these decision models even better, to decrease the number of follow-up CTs that we really need to do and the cost to the patient and the radiation. But even the top performers require further refinement to improve accuracy in subpopulations. Models should be updated to include data from the ACR LCS registry. I think what we're learning as we determine and tend to screen more people, we're going to have a tremendous amount of data that will be helpful for us in dealing with incidental nodules, not just with screening. And future iterations should estimate personalized risks incorporating local screening center accuracy and operative mortality. So this is a little bit more addressed to screening, but I think also applies to incidental nodules. So in summary, the solitary pulmonary nodule drives us crazy, as well as the multiple pulmonary nodules that we see on chest CTs in patients who are having chest CTs for nothing related to malignancy, and we have to make decisions of how they're going to be managed. And we need to look at the clinical risk factors, and I recommend that you make efforts to go into the electronic medical record. It's become much easier now in the days of PACS and the integration of all the information sources. We have EPIC, which isn't the easiest to use, but it's very easy to search, at least for smoking history and age and so forth, and put this in your report and take that into consideration when you make recommendations based on the Fleischner Society. So we need to assess clinical risk factors, socio-demographic, which will be in the medical record, but the size, the location, the morphology, classic benign features, as I've mentioned, and the growth rate, make every effort to see if there are previous studies and solidity. Okay. And if there are any questions, I'd be happy to answer them, and that's my email address. Thank you very much for your attention.